Impingement syndrome is a chronic condition in the supraspinatus, the long head of the bicep, and the subacromial bursa. These structures become entrapped within the subacromial space. The chronic inflammatory condition results in the thickening of the bursa as well as the tendons that lead to a decrease in that suprahumeral space. The suprahumeral space has three components: the ceiling, the floor, and the soft tissues. The ceiling consists of the acromion process and the coracoacromial ligament. The floor is the humeral head. And then the soft tissues that run through this space are the supraspinatus tendon, the long head of the biceps tendon, and the subacromial bursa. There are three stages of impingement. Stage 1 consists of edema and hemorrhaging. This is what you will see in individuals who are under 25 years of age. Stage 2 includes scarring and fibrosis, and this occurs during ages 25 through 40. And then stage 3 includes a tear of the rotator cuff and the long head of the biceps. This occurs as people get over the age of 40. Nair created a chart of the rotator cuff impingement stages and listed the different stages. Additionally, Nair included the symptoms that you will see as well as the physical signs in each stage. Primary impingement is going to be due to abnormal excursion of the supraspinatus tendon under the subacromion arch. There are several things that can contribute to this problem. The person may have an irregularly shaped acromion. They may have coracoacromial ligament thickening. There may be an AC joint spur and or degenerative joint disease. There could be ossification of the ligament. They could have an os acromiale, which is hypermobility with an anterior projection or a spur. There may be rotator cuff tendon thickening, scapular dyskinesis, or a neuromuscular dysfunction, the timing of the contraction of the muscles being off. Secondary impingement generally consists of glenohumeral joint instability, most commonly occurring anteriorly. There are other types of impingement syndrome as well. Internal impingement is when the arm is in 90 degrees of abduction and external rotation. In this position, the contact between the posterior glenoid rim and the posterior aspect of the insertion of the supraspinatus and the superior aspect of the infraspinatus insertion into the posterior greater tuberosity causes an inflammation. There can also be a coracoid impingement when you have a decreased distance between the coracoid and the anterior humeral structures. Kibler first described impingement syndrome in baseball pitchers. He stated that baseball pitchers with tight posterior glenohumeral joint capsule and muscles have a decreased internal rotation. This leads to an increased protraction and an increased impingement during ball release and follow-through. So this impingement syndrome is something that is very commonly seen in baseball pitchers because of that phenomenon. Again, when you have a tight posterior glenohumeral joint capsule, you have decreased internal rotation, leading to an increased protraction and an increased impingement during ball release and follow-through. Mechanism of injury for impingement syndrome is typically insidious. Signs and symptoms can include a scapular dyskinesis. One thing that you can check is your patient's posture. Do they have a forward head or a cervical lordosis or perhaps a thoracic kyphosis? The thoracic kyphosis results in a tightening of the anterior joint capsule and the glenohumeral ligament. This can also include an anterior scapular tilting because of the tight pectoralis muscle. Signs and symptoms include deep anterior shoulder pain, localized pain over the supraspinatus tendon insertion, localized point tenderness over the anterior acromion, localized point tenderness over the long head of the biceps in the bicipital groove. Usually those are going to occur during activity in the impingement position. The patient will also complain of nocturnal pain, and they will have pain with greater than 90 degrees of shoulder abduction and or flexion. Range of motion wise, we're going to look for the painful arc syndrome. This painful arc syndrome is 60 degrees to 120 degrees of abduction. In this position, the suprahumeral space is compromised, compressing structures within the space. There are several tests that we will perform in order to determine this pathology. In the crossover impingement test, the examiner stands with one hand on the posterior aspect of the subject's shoulder to stabilize the trunk and the other grasping the subject's elbow at the test arm. With that stabilized trunk, the examiner passively and maximally horizontally adducts the shoulder across the body. Anterior shoulder pain is indicative of subscapularis, supraspinatus, and/or biceps long head pathology. In a posterior impingement test, this patient is going to lie supine on the table with the test shoulder in 90 to 110 degrees of abduction and 10 to 15 degrees of extension. The test elbow is flexed to 90 degrees with the examiner sitting or standing beside the patient. The examiner is going to slowly rotate the patient's shoulder into maximal external rotation. Reproduction of the patient's pain in the posterior aspect of the shoulder is indicative of a rotator cuff pathology. The near impingement test is basically a passive shoulder flexion test. With the subject's scapula stabilized, the examiner is going to passively and maximally flex the test shoulder. Shoulder pain and apprehension are indicative of that shoulder impingement, especially when we get to the end range of the flexion. In a Hawkins-Kennedy impingement test, the examiner is going to stand with one hand holding the patient's elbow and the other hand holding the subject's wrist of the test arm. We will flex the elbow to 90 degrees and forward flex the shoulder to 90 degrees and then internally rotate the patient's test shoulder. Hawkins is the first part of the test of actually rotating the shoulder. Kennedy is moving it across the body horizontally to place the shoulder in different positions. Shoulder pain, apprehension are going to be indicative of shoulder impingement. Manual muscle test will be an empty can test. Diagnosis will be via x-ray to rule out bone spurs or humeral flattening. Treatment will be conservative at first with a postural alignment, scapular stabilization to help strengthen force couples, especially the serratus anterior and the lower traps, and glenohumeral joint stabilization. The need for surgery will require an anterior acromioplasty to increase space for the suprahumeral structures to move.